Welcome to the Transcend Health Solutions podcast, your go-to source for insightful discussions on ketamine-assisted psychotherapy and all things mental health. Join us as we explore innovative treatments, share expert interviews, and offer practical tips to help you navigate your mental health journey. Tune in and discover how you can transcend the challenges and embrace a healthier, happier life.
Today we have Kelly on the podcast, and what we're going to be doing is, hold on, I didn't introduce you nearly enough.
No, that's
Kelly,
good. We can keep it to that.
Kelly Light, a registered nurse for how many years?
16?
16 years. So she seen some things.
17.
A lot of cath lab work, but experience
A lot of
across the
cardiac
board.
stuff.
Lots of cardiac stuff. Kelly, how long have you been working at Transcend?
It's been almost 2 years now.
2 years. So, in 2 years, you do a lot of sessions. What we wanted to do today was go to the Therapeutic Ketamine Reddit and just read through some of these questions. Try to keep them anonymous, but just answer the general questions and see if there's any themes in some of these things. Because when we read through these, there's some concerning stuff, not only in just the questions, but also just kind of the answers back, not only from other people going through ketamine treatment, but other providers. And so hopefully
A lot of places don't do it right, so
yeah, and I mean,
that's to be expected.
I'm sure there's some great places out there too, and those places don't generate people going to Reddit for questions. And so this certainly isn't representative of the entire ketamine industry as a whole, but it is probably representative of people who are struggling through ketamine treatment going to places that maybe don't do this quite as robustly. And so we were kind of hoping to shed some light from the perspective of a clinic that, tries
operates
our best.
ethically.
Yeah. All right. So
Sounds like a plan.
we're going to take turns answering them, and hopefully y'all get something out of it. So the first one here, we'll just go from most recent down, is feeling worse after an infusion today. They said that they've felt better generally after infusions, but today they can't stop crying, and they say, WTF, is this normal? What are your thoughts there, Kelly?
My thoughts would be that it can be pretty normal if that session brought up a lot of emotion, brought up, some trauma, that every session with ketamine is different, and so not to get caught up on comparing it to how the other sessions went, and that if that session was really emotional and there's a lot of tears that need to be released, that just trust that that's what needed to happen and let it all out.
Yeah, I think that I always like to compare ketamine treatment to regular therapy, standard talk therapy. If somebody told me that after a standard talk therapy session, they were feeling pretty raw, they were feeling, rough, everybody would be like, well, yeah, that sounds like, normal. That's completely the case. And a big piece of how ketamine works is it helps things come up from the unconscious and become conscious so that we can process them. Sometimes that comes up in ways that it's pretty easy to identify what we're actually experiencing, and sometimes we just get kind of raw emotion. Particularly for trauma that was more pre-verbal, it may be really difficult to identify exactly why someone is experiencing a certain emotion after. And what that usually speaks to me is that normally happens during the session and in the clinic while we're here so that we can actually process it. But if somebody isn't held in a container that will allow that to happen there, it's not uncommon that they're just mowing their lawn the day after, they're in the shower, they're whatever it may be, and all of a sudden they get hit with a large wave of emotion, and they can't really identify what it's about. And so those times are really critical because that process is probably really important and really needs to be handled well, and mostly just embraced. And so I think it's really critical to parse out the idea that ketamine is supposed to just simply make you feel better. That would typically be a very transient situation where, okay, you get this temporary symptom reduction, what's the long-term plan for that? Very oftentimes how somebody doesn't need ketamine treatment anymore, they need less maintenance treatment, is kind of embracing those challenges, processing through that, and that's what actually creates kind of long-term change. And so if someone is concerned that they're experiencing some really raw emotion after, which could be from an emotional flashback, could just be things coming out of the unconscious, or could have been unrelated to the ketamine. I think sometimes it's also really important to not over leverage. People have waves of emotion come up in days, sometimes for no reason at all. And when you're in and around
Right.
ketamine treatment, it's very easy to point your finger at that ketamine treatment as the reason. And it probably was in this case, but sometimes it's unrelated. And just, I think it's really important to, be a little objective here. And, was it even related to this treatment or not?
And I'm curious if they had therapeutic support during, or if this was an infusion-only clinic. Because like you said, if they would have had some therapeutic support, they could have possibly processed it while they were there. It reminds me of when I had an infusion at another clinic where I didn't have therapeutic support, and things came up about my dad who died when I was young, and I didn't cry there. But the next day when I was safe at home with my husband, then I cried and let it out. So maybe that they just didn't feel like they were in a safe space there, and then the next day all the emotions that kind of came during their infusion flooded out.
Yeah, so I mean, simply put, this is normal. Certain diagnostic subsets, it will be much more normal. And the main thing is to kind of embrace that process. And if you have outside therapeutic support or therapeutic support at the clinic, letting those providers know. Obviously, this person's reaching out on Reddit looking for support, so chances are they don't already kind of have something robust set up.
Right.
Maybe they do, and they're just hesitant to actually process that stuff, but highly encourage anybody experiencing any challenges along the way to get some integration support, either from an outside therapist, somebody who's specialized in this, or just finding a clinic that can provide that. But
It's
just
an important highlight to make right now is to, if you have one in your area, to make sure you go to a clinic where you do have therapeutic support and you're not left in an infusion or in an IM injection alone in a room to process all this by yourself, because that can be really dangerous.
all right, let's tackle the next one. Do you have one that you want to read? I got one here
Let's
too.
see. Oh, you got another one already?
Yeah.
What's yours?
Basically, this person is kind of talking about, in my mind, being a little bit in the middle of the treatment process. So they say they're on the third session. It's starting to be challenging, and they're kind of maybe questioning continuing on to a full series. There's a couple pieces in there
Okay.
that I think are worth discussion. Number one, a lot of times ketamine treatment is a little bit like climbing a ladder and then kind of coming down the slide on the way down. And when somebody's in the middle of that process, it's extremely difficult to think that this is helping, because actually they're a little bit more distressed than when they started, and easy to give up in the middle of that process. When I've talked with a lot of infusion-only clinics, that's actually one of the biggest challenges they have, is people just dropping off in the middle of the process because they're unsupported.
Because it gets harder before it gets easier or better a lot of times.
Yeah, and that's part of the informed consent that you should ethically provide to anybody going through this is, and we harp on it, intake several times throughout, so someone's because what happens is we get to the middle of the process and things actually are a little bit more challenging for some people. Sometimes it is symptom reduction along the way, but it's more common for it to be challenging before it gets better. Same with standard psychotherapy. And essentially, if we've already had that conversation from an informed consent standpoint, it's a very simple conversation, because it's like, remember we discussed that it might be more challenging before it gets better. We're really encouraged to continue on. And it's also really important. Been spending a lot of time basically getting out there into the community to inform outside therapists that this is possible, because it's probably pretty normal if you were a therapist and someone came into the session and they were saying, hey, I'm doing this ketamine treatment and like everything's worse. I'm not sleeping as good. I'm way emotional during sessions and after, and just generally feel worse. It would probably make sense for that therapist to just be like, well, maybe this treatment isn't for you. Maybe this is actually making things worse. And, same as comparing it to any other medication or any other process. And so, but this doesn't really fit into that paradigm. It's normal, expected, and something that, we deal with every patient coming through this treatment. The second piece of this that is a little bit concerning for me is that idea of like that magic number 6.
Yeah, getting attached to that this is all going to be done and wrapped up in a tidy little bow after this many sessions.
Yeah, so when we first started, we did a lot of the things that a lot of other people did, other clinics did, those packages of 6. Hey, come in. We wanted people to at least give it a full try. So we'd say, hey, come in and do 6 sessions. The challenge is for some people, they need 10 sessions. For some people, they need 8. For some people, they just needed a 7th session. And they wouldn't do the 7th session because they had in their mind that by 6, they should be good to go.
Mm-hmm.
Well, similarly, sometimes people are good to go at 4 sessions and they don't need more sessions, and it wouldn't be appropriate to do session 5 and session 6. It's more important to focus on integration or just the work is done. There was a less complex issue, less to get to, and we're able to handle it in a shorter amount of time, or we need a little bit more time. And so we try to give a projection of how much treatment we think somebody's going to need based on their history and their distress and everything that we can guess, including our experience with doing it. But we should just get rid of this idea of magic number 6. Where that probably comes from is these original NIH studies where we looked at protocols where we give 0.5 milligrams over 40 minutes for 6 sessions in a certain amount of time, and then we should see X amount of symptom relief by then.
Yeah, which makes sense for a study. You have to have some sort of protocol like that, but for the real world, that doesn't translate.
Yeah, like that would, if I said every single patient needs exactly 30 therapy sessions, that would be a really weird statement. No one would get down on that. There isn't a therapist out there that would be like, there's this magic that happens in between on session 30. So why do we do that for
ketamine therapy? That's true.
So it doesn't really fit, and I think very oftentimes we need to take these really known truths from standard psychotherapy and blend them into this treatment because it makes things a little bit easier to understand, but it feels different for people. And so it's very common conversation in the clinic to talk to someone about like, yeah, we're on session 5 today and we're going to do session 6 next week, but this is going to take the time that it's going to take for you. There's not anything wrong with the fact that it's taking a little bit more time for you, or that you happen to have really kind of been in a good place early, where there's no reason to do some specific number. So those are the 2 things that I think but I think the main encouragement is if someone's in the middle of a series, they should be most likely, more oftentimes than not, but particularly people with trauma history,
mm-hmm.
feeling a little bit rougher than when they started. It's really difficult to dive into some of these things, and whether somebody's therapeutically supported or not, or just trying to like shove that stuff out, it's not really possible with ketamine treatment. So it's normal to have a wake from every session, and sometimes that can feel pretty rough, and sometimes that can feel really great. But it's usually different each time, so we can't really project what any one session is going to feel like.
Yeah, and another reason why we try to reiterate to clients not to judge each session at the end, and just to kind of wait and look at the bigger picture, wait until you've done a handful, and then kind of judge, how much progress you've made, and not scrutinize, each and every session that you do.
Again, that would be so weird to do in standard therapy, right? Like you get to the end of the session with your therapist and you're just like, I don't know, I still feel like I did when I walked in here an hour ago.
Mm-hmm.
We don't do that. That would be really strange to do, and it's strange that we do it with ketamine sessions. I've had patients who are on the way down from a ketamine infusion, and they're like, it didn't work.
Yeah.
They're still depressed.
Sometimes the pump is still going,
yeah.
And they're saying that.
Yeah.
And
it just didn't work today, and we're in the middle of it.
Yeah. You're already disappointed, and we haven't even finished.
Yeah. And so, which obviously is an opportunity for someone to process the disappointment that they're experiencing overall, that right now is kind of getting focused on the infusion that they're actually in. That doesn't even make sense, but they're feeling that emotional experience, and they're just trying to figure out where it should fit. And when they can't think of any reason why it would be, because it's painful to look at why that might be, the easiest thing to do is just be like, it's this experience today, or what I'm currently experiencing, this entire process, or that. And it's important not to get fooled by that, because people waste a lot of time during sessions actually processing whether or not it's working.
Right. Or comparing it to the last session.
Yeah. Every session is going to be different. What's useful in one, it might be a completely different process in another. So there's no point comparing one session to another or weighing in on where you're at until you're done, because all of that is just wasted time. And so certainly it's important to vocalize those concerns along the way with the people that you're working with, but it's generally a waste of time to be like, it didn't work yet, it didn't work yet. I make this analogy, and I don't know if anybody will understand it, but it's just the way it fits in my brain. I call it pulse checking, and it's something you'll understand or have a lot of experience with. But when in CPR, a lot of times I've seen this in emergency rooms where all of a sudden we get to a certain point in the code, and it's like, okay, do they have a pulse now? And then we'll just spend like 10 minutes just checking pulses, like check the femoral artery, check the carotid artery again. Let's get the Doppler out, And they just start doing this to the point where it's like, is anybody going to go back to CPR? Like clearly there's not an obvious pulse, and somebody dies in that process because of this.
Well, that's why they don't teach it like that anymore.
Yeah.
They don't do pulse checks.
Culturally, it's been very difficult
CPR.
to get out of the processes in the ER, but it's something you should definitely avoid because it wastes critical time. And so doing that process of like, am I there yet, am I there yet, is just taking time away from the actual work. And so I always try to tell people is just that we as clinicians are going to kind of tell you where you're at along the way. We'll probably remind you mid-series, like, it makes a lot of sense why you're feeling the way that you feel right now. And as we start to come to a close in the process where we can really tell from your metrics and otherwise just how far along you are, we'll talk to you about that. And so there's just really not a lot of point in, spending a whole lot of time. I mean, again, casual, this coming up from time to time is no big deal, but like I've seen entire sessions spent on, is this process for me? What am I even doing here? What am I getting out of this? And it's like, we are in the process right now. So we should be focused on the process and not just, is it working?
Mm-hmm.
But
people put a lot of pressure on themselves to get better quickly and for it to work, right away. And I think that is a setback in progress too, instead of just being open, letting it be what it is, and not applying the hustle culture that is, part of life in America right now to your mental health. Just trying to get better fast, process your feelings right away, and be cured for life. It just doesn't work like that.
So there's a lot in this next one.
Is it the first ketamine horrific one?
Yeah, do you want to read that one?
Did my first infusion today. I'm a 145-pound female, 36 years old, raised by 2 full-blown narcissistic parents. CPTSD, depression, anxiety. They started me at 50 milligrams. I got the full dose of Zofran, which is an anti-nausea med. I was leaning back in a recliner chair. Shortly after the injection, I started feeling woozy, so I laid my head back and let myself go with it. Darkness everywhere, pitch black, horrible feelings, scared, lost. I was disintegrated until non-existent. There was no point to existence, all negative feelings for the entire thing. I couldn't move. I had no control of my body. I was afraid I was going to die. I was afraid I did die. It felt like I had died. Everything I knew of. Whoops. Disintegrated into particles, but I could still feel only negative things. In the darkness, I kept calling for help and no one came. Praying and begging God for help over and over, and no one came. The meditation music I was listening to turned and sounded like horror film music. It added to the torture instead of helping it. When I slowly started to feel my body sensations, or that I actually existed, my neck and back were in intense pain from being tensed so hard. My mouth was dry. I kept crying and crying. The nurses looked a little stumped. It was taking me so long to recover, but kept doing their best to help me. There was a horrible smell in my nose. I had severe nausea that took me 2 hours to recover enough to walk, and had to go home in the car. Now I'm at home in bed feeling traumatized and nauseous. So what happened? Why is it like this for me? Which makes me so sad that this person thinks that they had something to do with this terrible experience, when clearly they went somewhere that is not operating ethically. For one, like our therapist Anna said when we talked about this post yesterday, if this patient wasn't told about the possible side effects, then they weren't given enough information to have given informed consent to get the ketamine. They weren't told that it could be terrifying sitting in a room by yourself with a ketamine injection. They weren't told that you could have nausea for several hours. They weren't told that you could have ego death. Then they were not well prepared. Other huge red flag is that they were alone in a room after an IM injection. And IM injection, the ketamine comes on very quickly, and with no support, it can be absolutely terrifying. The therapist is there to ground you, to tell you that you're okay, to make sure you're safe, to make sure that the level is not too deep. And to do that without any support, to me, is egregious. I don't think those clinics should exist. I think there's so many people that will come and do this and then just think they're broken and it didn't work for them and never try ketamine again. If they had done it with therapeutic support, it could have made a huge difference in their life. So this is the problem with what's out there, and why it's so important where you go, and why you have to do your research and make sure you're not going to a clinic like this.
Yeah, there's so much here. Obviously the lack of support's the primary thing, because even if the dosing wasn't great, even if so many of these factors, nausea, etc., could have been done better or otherwise, even if there had just been support for someone to know that they're not in fact actually dying, sometimes
that's enough sometimes to
as
hear
simple
that,
as you need.
hey, we're watching your vital
Yeah.
signs, your heart's great, your blood pressure's fine, you're safe, and you're still in the chair the same way you were before this started. Just hearing those things sometimes is enough.
Well, and my guess is it sounds like there were nurses in the clinic. So if they had actually, and who knows what the situation was, but if they had actually been yelling out, "Am I dying? Is everything okay?" Most likely a nurse would have stepped in and be like, "No, these are normal effects, etc." But the thing is they were given an IM injection that was dosed to a degree that my guess is most likely nothing was coming out audibly.
Mm-hmm.
They were most likely
Too deep.
In the experiencing this, unable to actually vocalize that they needed anything. So that's why you have to do check-ins throughout a ketamine experience, at minimum every 5 minutes, and better yet, a live dialogue, because in the Ketaverse, 5 minutes is a very long time. So someone can be okay at one check-in, and then you wait throughout this period of time, and if you don't have vitals to tell you that somebody's actually distressed, because that's something that we can register. If I see a spike in heart rate or blood pressure, I can immediately tell the therapist, like, "Hey, I've seen a 20-point rise in their heart rate, check in."
Yeah.
And a lot of times when we check in that situation, the patient isn't even aware of what their body is already starting to respond to this thing. Some anxiety is actually coming on, and then it's actually developing as we're telling the therapist to check in. They're like, "Yeah, now that you mention it, I'm feeling kind of anxious." It's like actually coming on at the moment in which we're actually recognizing that it's happening. So that's kind of critical to make sure that things like this don't happen. Because even if you're just checking in, every 5 minutes or just once in the middle or something, somebody could have been experiencing what felt like a lifetime of distress in between those check-ins.
Right.
So that's not okay to just, walk out of the room and then come back later and see how it went, because it can be completely legitimately traumatizing. And we get those calls a lot. The other aspects that are kind of worth discussing is, sometimes you actually see clinics that think that it's appropriate to use a call bell.
Right.
And so here's a clear situation. This might have been, their situation. The nurses are thinking, well, then why didn't you just hit the call bell?
Yeah.
If you're having a problem, why didn't you just hit the call bell?
I don't think those nurses have had a ketamine infusion.
Yeah. Well, it's extremely difficult under most ranges of ketamine to, make a purposeful movement like that. I'm actually always surprised when someone does reach over and adjust the chair or something.
Yeah.
I'm just how did
their
you
neck. Yeah.
do that? Scratching your nose during the middle of a ketamine experience can sometimes be an incredible challenge, because it does have those dissociative components. And so really great control over your body is very difficult, especially hitting a little button, things like, or even remembering what a button is.
That
or
you can't talk, the feeling that you're kind of trapped in your brain and you can't talk, where if you have someone talking to you and checking in with you, then you can answer. But to just be alone and have had nobody initiate anything,
Yeah.
I can totally see how she wouldn't have been able to advocate for herself. And then the fact that it was IM and came on really quickly is another reason why it was probably so terrifying, and why she had such severe nausea. And one of the reasons we only do IV. We have control over the rate. We have control over the level. You don't get as nauseous. So it's more efficacious. It works better.
Yeah, and just the challenges with IM is all of the ketamine comes on very rapidly. And so it's kind of like climbing on a rocket ship. We don't do IM injections here unless it was like just an absolute last resort situation. And even if we were, what we would do is you would do multiple injections. And so multiple small injections, that way you don't go too deep into the experience too rapidly. And that's actually fairly challenging to do, even with I hate doing this, but as much ketamine experience, as I have experience with administering ketamine, I don't like doing IM sessions. It's incredibly difficult to land it. Every single time I'm doing one, I'm like, I just wish I had an IV in, because, if I had gone 5 milligrams less on this, we would have probably landed it. But I only know that now after I've injected it. And last time that dosing was just fine. Ketamine sensitivity varies wildly day to day. And so trying to make a projection of like, okay, last time we did, 2 doses of, 0.45 mg per kg, and that went, pretty well for this person. Maybe entirely different for someone this go around. So those big like lump doses of, oral ketamine or IM ketamine or otherwise, you kind of don't know what you're going to get on a given day. And
with IV, we can adjust it in real time, and you're going to see a change in a couple of minutes.
Yeah, and also the music, sounding like a horror film. So, we have playlists that we've edited and edited through time that generally go well for most, but one person on a given day, they can hear like the most peaceful song in the world, and they're just like, what is this? Like this crazy devil music that y'all have on. And we're like listening to it externally. We're like, it's Tibetan singing bowls and nice, singing, but all right, cool. Sounds like that to you today. And so
we can change the playlist.
Well, and how important the music is. I actually had
so important.
Patient this week where I was listening to the music that we're playing right behind the person. It's very critical that the music is of high quality, as well as, either, I don't like headphones because you can't talk to people without lifting up the headphone, which interrupts the experience, but either something immersive like that or speaker right behind somebody that's actually fairly quality. But the cord was a little messed up, and it was kind of giving a flat response. It was hard to pick up on. It's just some kind of an audio file. So I was just like, what is up with the music? There's no bass in it and stuff like this. Basically, just told the therapist, like, hey, I don't know what's up with the music, but it sounds kind of weird to me. They adjusted the cord, and it got way more high fidelity really quick. And the person immediately said that the experience changed dramatically, that it was way more immersive, that they were not fighting to be in the experience, but they were fully in the experience. And then just the session kind of took off. It was just an audio phenomena that, so anyway, just the importance of the music throughout
being something that the client resonates with and doesn't feel like a horror film.
Well, and this is the stuff that I think insurance companies and whatever are just going to really struggle with understanding, is like, how critical the music is, right? Like it doesn't sound like an important variable, but it's a synesthetic medication, and so what music is on largely dictates what the experience is actually like, which can play into how productive it is and how it feels for you, whether you feel safe or not. It is a massive aspect of it. And in my mind, it's kind of like ketamine and music. Like, it's a dual intervention. In other words, what the ketamine experience is like for someone is so largely dictated by the music that is playing, and all those factors, the fidelity of it, the dynamics of the music, all of these things, that it hinders the therapeutic process in KAP to not have that together. And I forget ketamine in silence. That is a horrible idea. Every single time I've ever seen anybody say, oh yeah, I'm going to do ketamine, I don't want any music on, or just turn it way down low or whatever it may be, the experience doesn't progress along. They feel very challenged by the experience, and usually we just barely put on some tones all of a sudden, and then they're just way better. And so highly encourage everybody to get rid of the idea of doing it without music. Music is a critical
or
intervention.
bringing your own music with words in, which we do allow from time to time, but I personally haven't seen it be very helpful. Bring your own metal playlist or
you don't want words in the process. I mean, obviously, if we've got KP going on, it's going to really stand in the way. But I think that it's just really important.
Yeah. Well, I hope this person does some research and finds a better place and doesn't give up on ketamine.
I've got 3 here.
Okay.
What is the highest dosage of ketamine for antidepressant effects? So it's interesting because they cited some rat studies and some things like this and whatnot.
Mm-hmm.
There's always this idea of more ketamine must be better and produce a bigger effect. That is not the case at all. There is a very tight therapeutic window for ketamine to have an efficacy for mental health benefits, and that is between 0.5 and under a milligram per kilogram. Very rare cases might do a little bit better above a milligram per kilogram, but usually those are people with extreme muscle mass or very different metabolisms of ketamine.
Mm-hmm.
I was about to say redheads, but that's kind of not
Usually
fully
they're
accurate. But
a little more sensitive.
there are some people that do have polymorphisms that associate with different metabolisms of ketamine that might need a little bit higher dosing to essentially establish a plasma concentration that would be equivalent to somebody without that metabolism issue.
Yeah, but it's still very rare.
Very rare. I mean, I couldn't even take a guess on it. 1 in 200 patients or something like this. It's very rare that we actually, 1 or 2 a year that we see that need above a milligram per kilogram. So the thing about this is reasons why. Okay, so we need at least enough ketamine to get to a certain plasma concentration to be able to have an experiential aspect to this. Usually that's above 0.5 by IV in that 30 to an hour range, 30 minutes to an hour range. And so to achieve that plasma concentration for most people. So you need to have at least that much to do the thing. So we try to always, we have a process of a goal dose that, we try not to give less than this, whether it takes a long time or otherwise, but a total dose associated with that. And of course, administration rounds are going to change all this together, whether it be oral, bioavailability differences. Otherwise, we're talking about IV infusions. But the challenge is as you go above a milligram per kilogram, and of course that time frame matters. Milligram per kilogram over 10 minutes versus an hour are really, really different. But as you go above a milligram per kilogram in a reasonable time frame, between 30 and 50 minutes, somewhere there, you're going to start to experience fully dissociative effects. What we know is that if someone is more fully dissociative, they are not going to experience the same degree of antidepressant benefits as someone who is actually a little bit more conscious in that experience. At the point in which it becomes where there's no memory of the experience, there's no ability to comprehend the entire thing. It's just way too far out. In other words, you were rendered unconscious by somebody.
It seems to be important to remember the experience. And also clinics that don't put you too deep but administer a benzodiazepine like Versed alongside can also highly decrease the efficacy just based on that, not remembering it and just being too deep, too sedated to not really do any work.
Yeah, this is essentially so pervasive in the industry that people are given extremely high doses of ketamine, and everything above a mg per kg just, and in the early days, we would do this, more regularly. We would be like, well, this case isn't really budging. Maybe we should kind of go up in dosing. Like I get where the mindset comes from. It makes a lot of sense. And so we would every single time I got above a mg per kg, extreme nausea, way less response. It just
have a lot of
isn't appropriate.
People commenting back to that, the person that posted that, saying the same, that anytime they got above a mg per kg, they got very nauseous.
It's so direct. So few people will, and that's because of these secondary metabolites associated with ketamine that can contribute to more nausea. People have a certain amount of liver enzymes. They can process so much ketamine, but above a certain level, you really start being challenged with that. And people have experienced that with alcohol, right?
Yeah.
2 or 3 drinks are one thing. 10 or 15 are a completely different thing. And so,
more is not always better, folks.
Yeah, your dance moves go up as we start having some alcohol, and then they really start going down after a certain point. You're just you're lucky to do the worm on the ground at some point or another, and most likely pee your pants. But just from personal experience, I'm speaking to.
I'll have to see that you doing the worm someday.
I will bust out with the worm in this podcast on this table right now. Let's see here. So, do you have to get ketamine treatments for life? What do you think, Kelly?
No. No is my immediate answer. Some people, chronic pain, people that just really had horrific, significant trauma may need maintenance sessions throughout. But a weekly or even bi-weekly for the rest of your life, nobody. I can't see anybody that would be indicated for that. Chronic pain, monthly is I think the most we see.
So, I would definitely say it depends. I mean, is it impossible that there might be a case that the best thing for someone, given the severity of their condition, might be to do more regular maintenance, and that there might be real challenges around doing the deeper processing that actually allow them to get out of a maintenance phase. And this is just the best that we can do. And from a risk-benefit analysis, this is actually just the best intervention. How common is that situation? We don't see
Very
it.
rare.
So what we know is that when you appropriately therapeutically support people, they do way less maintenance. They spend less money on treatment over time. So that's kind of what I always try to talk about. People will talk about doing ketamine treatment. They're like, I'll just do the at-home lozenges because it's way cheaper. Well, it's not, because you're going to end up doing it for such a long period of time that you're going to spend so much money on this treatment process that you would have spent $3,000 or $4,000 in a KAP process versus spending hundreds of thousands of dollars over a period of time. Through
And
ketamine
you're not going to
treatment.
get the same results. I mean, it's not going to move the needle in the same way that IV KAP would.
Yeah, and I certainly understand why some people just might want a reprieve, and they want that reprieve over and over again, and it never really kind of fulfills that thing that they more deeply want. This is the narrative that has been professed, that that's actually a thing, but that is certainly a lie. Eventually that will run its course, and this won't be helpful anymore. It just isn't helpful to have any kind of psychedelic experience without integration, without any of this, as just out of the idea that this is actually treating someone's condition. It is just simply a transient reprieve that someone is re-experiencing over and over again. And I understand the argument of why some clinics might just say, like, this is kind of the best thing for this person, and this is better than X, Y, or Z. This beats them going to electroconvulsive therapy on a regular cadence. This beats whatever else maybe.
Yeah.
But
so you have the rare people that
is it completely impossible?
3 times a year.
But
for
I would
a
also
long time, but
argue that, let's say that was the situation, that somebody did need to come in, once a quarter or once a month, whatever it may be, for the rest of their life. That was actually the situation that they needed. And they're doing all the other things appropriate too. They're getting good psychiatric care. They're getting good therapeutic support. They're getting all the things that they need. And they actually find themselves needing that.
mm-hmm.
Well, there are so many conditions that need some form of regular maintenance
Mm-hmm.
to be able to actually, to live, to be able to manage the condition. And we're just fine with those in medicine. But for some reason, the idea of doing a regular ketamine experience really scares people. And usually that fear is, I think, what is this going to do to me? Because we don't really have great long-term data on what it would be like to do sessions. We don't know if that causes cognitive decline. In other words, we're talking about regular sessions. If someone coming in every 1 to 3 months, we don't have great studies on this. Nobody knows what exactly that might do. And so in medicine, if you don't have that data, then you have to take this as it comes from a risk versus benefit analysis.
Mm-hmm.
And that is almost never going to weigh to long-term regular ketamine treatments for somebody seeking this for mental health reasons.
Mm-hmm.
Chronic pain is a complete caveat because conditions like CRPS, we kind of expect long-term maintenance, and that is just fine. That is part of that condition, and
if it keeps you up from being dependent on opioids, then it's certainly warranted.
So a little bit of a nuanced opinion there, I would say. But in general, if someone's doing KAP, they should not be expecting to do this for the rest of their life. They should expect to do an intensive run of a series and then maybe some maintenance in the next calendar year. And most likely after that period of time, probably never do it again, except for, extremes.
Yeah. things come up in life. If things get hard again, some people do come back and have a mini series, have a couple of sessions if they're going through, difficult times. But it's not the norm.
I see one here on opinions of anti-anxiety meds for, IV infusions. What do you think, Kelly? Do you think that...
like what we were just talking about, like giving Versed?
Yeah. What do you think? Good idea, bad idea?
I think generally it's helpful sometimes to feel that anxiety and work through it. For some people, especially on first infusion, they can be really nervous and it can be too much anxiety. So sometimes a little bit of a beta blocker can help. So I think we're fine with that. But benzodiazepines, we do not recommend alongside infusion or taking the day of an infusion. That'd be what I have to say.
So exactly, in a algorithm of managing anxiety, and one, good prep, therapeutic support during. That's going to take care of almost all of it. From there, appropriate dosing route that we can actually adjust during. So titration is far better than anxiety meds.
Yeah.
And beta blockers can be useful sometimes, and they don't play into the efficacy of ketamine, but benzodiazepines do. And so we don't have great data to know how much yet, but we should probably expect that if we're administering benzodiazepines during a ketamine infusion, we're starting to make it be like, why are we doing this in the first place? Because it is going to play into the efficacy to the degree that it might actually start to weigh that this person shouldn't have even done the infusion in the first place. The nuance. Let's say somebody's anxiety or panic condition is so severe that, titration, dosing, therapeutic support, all of this, forget it. It's not even going to happen. We're not even going to be able to go into treatment. They're not going to be able to sleep the night before. They're not going to. I think probably in that case, it might make some sense.
Yeah. Well, if it was going to prevent you from getting treatment, then I could see where it would be useful.
And the hope would be that we don't need it every session and that we
Right.
can minimize how much we're actually doing. But 5,000 some odd sessions without a single milligram of Versed or Ativan or et cetera administered. Anybody who wants to make the argument that this is required, they're incorrect. They are incorrect. I've talked to so many providers out there that have never administered any anti-anxiety medications because they provide therapeutic support, they know how to titrate ketamine, they know how to dose appropriately, they know how to prep patients for what they're actually going to experience, and they make that anxiety productive.
Right. I've seen so many people have sessions where anxiety has come up, and then they feel such a sense of confidence and accomplishment when they work through it therapeutically and naturally that then they know that they can rely on themselves when they come in the next time to do that again.
So this next one, daily ketamine very likely suppressed my serum testosterone levels.
I don't know anything about this topic.
I'm not so worried about the serum testosterone aspect
the daily
of this.
ketamine. Yeah. Daily ketamine is just a general no.
It's probably doing a lot of things.
Ketamine on
the serum
testosterone?
testosterone being a facet.
Yeah, like if you're doing daily ketamine, your testosterone is the least of your worries.
Yeah, I mean, who knows if this is playing into someone's testosterone levels or not. I don't know if that's been studied. I've never seen a study on those two factors. I think the only hormone that I've ever seen related to ketamine treatment was studies related to estrogen and ketamine sensitivity and efficacy. But daily ketamine administration, there are so few situations that would make sense. If someone had burns all over their body and they're getting regular ketamine administrations to be able to do burn wound dressings, stuff like that, okay.
Yeah, then maybe.
You're in an ICU, you're in that type of environment, you're in that type of care. There might be some people who have CRPS so severe that they need daily administration, but obviously that's going to be a challenge for that ketamine to continue having that level of efficacy. It's going to dwindle in time with daily administration. In theory, if we administer ketamine, you end up with this neuroplastic window 24, 48 hours after infusion. We start stacking this. Having the brain in a chronically neuroplastic state, we want to kind of break down processes and sort of rebuild them. We don't want to just be like in this constant breakdown situation, the brain constantly trying to rewire itself. For so many reasons, but I think the maybe this is where we can tie in Matthew Perry real quick as a final
thought.
thing that we talk about here. Obviously, Matthew Perry was probably in this situation, where essentially it sounds like, and it's hard to know the facts and details of the situation, but he probably actually started out ketamine treatment hoping for some help. Now, he did have a pretty significant addiction history, and it kind of sounded like he was seeing somewhere pretty ethically, have no idea if it was therapeutically supported or not. Obviously, had the financial resources probably to go somewhere that was pretty good, so assuming there was good care. And it actually kind of sounded like they reached a crossroads where he started wanting to come in more frequently and asking for higher and higher dosages.
And they refused.
Yeah. Which
was the right thing to do.
That's the appropriate thing to do. The challenge is when that happens, which is not something that we see. We don't have our patients asking for higher and higher dosages or to come in more frequently. In fact, actually, most of the time, our patients are very anxious about coming in for a session and want to space it out as best as they can. We kind of deal with the opposite problem. We're more encouraging, like, yeah, let's continue the treatment series, But the point is that daily administration does run that risk of addiction. It is actually very challenging to become physically addicted, or should say dependent to ketamine. It's not a particularly challenging substance in that it's about where marijuana and caffeine are, in that. But even at fairly high doses at regular administration, it doesn't cause a significant physical dependency. But it does. It does cause that if it's administered very regular at very high doses. And the consequences of daily administration are things like cognitive decline, potential for bladder issues, cystitis, etc. Usually, oral ketamine administration daily, that's where we start to see a lot of issues with bladder concerns. When we're seeing people once a week for ketamine-assisted psychotherapy and they're 0.9 to 0.5 milligram per kilogram, we've never had a case of
anybody have an
cystitis.
Or never had anybody get addicted.
No, we haven't had a single person that I'm aware of that in any way. I also think it's just how we frame this. People really understand that, hey, this is something I do with a therapist. This is very specific.
This is not recreational.
Yeah, and
I've had many people say after their first infusion, like, I can't believe people use this recreationally. It just doesn't, because the setting that we're in is, I think, so different than when people use it that way that it's just hard to imagine. But yeah, it's a shame because then he found it from an outside source and got like 27 injections in several days and way too much. It reminds me a lot of Michael Jackson, like another anesthetic medication. That
everybody learned what propofol was all of a sudden.
Yeah. And these doctors that are giving people IV anesthetics to use in their house just because they're a celebrity. It's just crazy that they would risk their license for that, for $50,000. Was it worth it?
Yeah, I mean, it's really sad because it's hard to believe that they actually thought that was something that was, I don't know, helping him, But the thing about it is... I
don't know if that was their intention, was to help him.
Who knows? But the where I'd like to take this, there actually are telehealth prescribers that are right now in the U.S. sending injectable ketamine to people's homes.
Mm-hmm.
Which
how is that legal? I don't know how that even happened. How is that a thing?
I believe it's one of those things where you can do anything you want until you get a letter from, a State Department or, the DEA or otherwise that says, hey, what the hell are y'all thinking?
Yeah, I mean, because we've heard firsthand stories from people that had really awful side effects doing it at home. It's not safe to do it at home.
Yeah, and they're saying, subcutaneous administration, which is a bad idea for ketamine anyway. It's got a very low pH. You inject it subcutaneously. You can get sterile abscesses, and so that's a risk of doing it. Expecting people to be able to differentiate, subcutaneous versus intramuscular injections,
right.
Or to ensure to aspirate to make sure that they're not, injecting into a vein or an artery.
Yeah.
Obviously, see, and this is where the conversation gets nuanced because people are like, oh, well, insulin. People inject insulin.
Well, they go to the doctor's office and they're taught how to do that, like in a clinical setting.
Yep.
They're not watching a video, which is probably how they're doing it. Like there's somebody signing off. There's a nurse there. There's a doctor there. making sure this person knows how to administer insulin injections.
And as a paramedic, I can tell you people screw it up all the time and they end
Yeah.
up dead from it. And so it's not something that we can just be like, oh, people do it with insulin. Yes, and people die from bad insulin administration all the time. They didn't check their blood sugar beforehand. They give themselves a big old dose of insulin just like they do normally and end up dead doing it, you know? And so this isn't something that's safe in any way. I think the Matthew Perry, it's such poor timing too, because like these companies rolled this out like basically in the wake of Matthew Perry, right? So if that wasn't enough of a signal to not send people home, you know, with injectable ketamine, then I just don't know what could be.
Pool or a hot tub in their backyard.
You know, and it comes from the fact that they're prescribing people oral ketamine. You know, that most of these clinics, what they do is they tell people to hold it sublingually, and then as soon as they start feeling the effects of ketamine, to spit it out. And they don't monitor the situation, so they give a very high dose. So in other words, the dose, if they had swallowed it, is usually very, very high, and you know would be the type of ranges that people could be either very challenged with or might actually, you know, be more likely to develop an actual medical issue, some hypertension, things like that, laryngospasms, etc. So anyway, you know, I think that we kind of started with just talking about, you know, basically like the daily ketamine administration, you know, actually supplying injectable ketamine to people at homes. And I think one of the challenge, like where all this screwiness comes from is ketamine does have a safety profile that is so great that even when done just horribly wrong, sometimes people still end up living through it and, you know, see it another day and continuing on like that. So it's actually taken a lot to see a case example of like, hey, here's somebody who injected it in a hot tub and they injected just tons, you know?
Yeah.
So I hate seeing people, our success rates are somewhere above 80% of being able to get people from suicidal and highly distressed down to not even answering questionnaires like they have a mental health condition at all in like 6 to 10 weeks. This is a life-saving intervention for so many people. I've seen more people have, you know, I mean, it's kind of like
we get to see it all the time here. It's one of the best things about working here. So
the idea that completely different situation, this would be like if after, you know, after Michael got, you know, the propofol, they just took all the propofol out of every OR and they just said, y'all can't use this medication anymore. Clinicians who know how to use it and how to administer it and how to do this safely, we should not lose our ability to be able to do this service ethically and well because one person injected ketamine in a hot tub. This is not.
But I do hope it puts a little bit of a microscope on all the at-home ketamine. And I hope that will stop or at least be a lot harder to do to just get ketamine shipped to your house.
And this is not the only death. There have been a lot of deaths from online telehealth prescribers. And for me, that's what's so bothersome is I see posts all the time from psychiatrists saying this is going completely fine. Well, I can tell you as someone who runs a clinic that I know of at least one patient who was young who did die doing that. That was one of our patients that discharged an online telehealth prescriber to save money. They actually ended up spending quite a lot more money and ended up, you know, essentially brain dead. After the process, they aspirated a hypoxic brain injury and ended up brain dead. Their mother called later to tell us about it and told us to warn our patients about this.
Terrible.
So I know of an instance. I know of other providers that know of instances. We are seeing this. I don't even know if these telehealth prescribers even know what the death toll has been.
Because I don't think they do.
I asked this patient's mother, you know, I think I should probably sue. And she's like, well, she overdosed. This is not their fault, you know, but they prescribed her 30 days of ketamine and she took it all at once. And so there's a lot of these scenarios where essentially maybe the actual prescriber doesn't even know that there was an issue. This person just dropped off. They don't know anything other than that. So I think the scope is completely unknown of exactly what the problem is until it manifests with like a celebrity. And then it's like, okay, well, no one can really deny this one here.
Yeah.
And so anyway, all right, that was a good little run. I don't want to make this one too long.
That was fun. And we encourage people, if you listen to the podcast, post some more questions on Reddit, and we'll do another one of these if y'all liked it.
Yeah, we're going to try to put this on Reddit. Hopefully I'll listen to it, comment some questions. We will get to them. Hopefully this is really helpful. I hope this can be a service to this really awesome community. Therapeutic ketamine, looks like so many people are just trying to help each other get through this process and just grow the field as a whole. And I'm glad that it's here so that people can get some support, not only from people who are also going through this and have some community, but also some providers chiming in there. But,
For sure.
hopefully this helps. Kelly, all right, sign us out here. I'm waiting for something, Kelly. Ajan.
Okay, that was fun.